RetinaRounds, podcast number 14. Multimodal imaging has become indispensable in the management of a wide variety of medical retina conditions. Increasingly, the role of imaging has extended into vitreoretinal surgery, allowing vitreoretinal surgeons to have new insights on the detection, prognostication, management, and postoperative surveillance of surgical conditions. In today's podcast, we're excited to welcome Dr. Anibal Francone, retina faculty member at the Charles Centro Oftalmologico in Buenos Aires, Argentina. Dr. Francone has made impactful contributions on the interface between imaging and surgery, and in today's podcast, he shares his insights on new imaging modalities for vitreoretinal diseases and his role in building a robust clinical research program. Let's check it out.
Welcome, everybody, to the RetinaRounds weekly podcast. It's our great pleasure to have Anibal Francone from Buenos Aires, Argentina, with us today. Dr. Francone is one of, if not the top vitreoretinal surgeon in Argentina, although I'm sure with his humility he will say he is not. He's an innovative surgeon and has pioneered some new techniques and has faced some unique challenges in Argentina. Anibal, welcome to RetinaRounds.
Thank you, Steve, and I want to thank you and Pradeep for the invitation. It's an honor to be here.
It's a great pleasure to have you. Tell us a little bit about your journey into medicine. Before you were a doctor, what influenced you or who influenced you to become a physician and surgeon?
Okay, well, my dad was a urologist. My grandmother was a nurse. I never imagined to be involved in medicine at all, to tell you the truth. I used to go with my dad to his surgeries, but it was during my teenager era, and it was thinking about many things around, like partying with friends and going out doing sports. But I really think about what you want to do in the future. But when it comes to decide about that, it turned out to be that it was natural. I just apply for medicine in Argentina, and then I start studying and moved to ophthalmology because I didn't find urologists as interesting as eye diseases. So it was a natural path.
And you knew you were going to be a surgeon from the moment you went into medicine?
No, you know that I never been in touch with ophthalmology. I didn't know that even that ophthalmology was a surgical subspecialty. I asked for when I was finishing my medical school, and I asked for some advice from eye doctor colleagues, and none of them told me that ophthalmology was a surgical subspecialty. And during my last year, and I asked to go to the OR, and I discovered that it was a ophthalmologist doing surgeries, a cataract surgery. So, and I tried to get into the OR, and the surgeon kicked me out. So he made me wait beyond the door, and so I was like kind of spying through the window of the OR. In Argentina, it's really difficult to learn surgery. Nowadays, it's easier. We have more. There are more open mind, but it was really tough.
And where did you study medicine?
Well, now I'm based in Buenos Aires, but I was born in a small town in the middle of Argentina, in the state of Córdoba. So Córdoba has one of the oldest university in America. It's like 400 years old. It's a University of Córdoba. So I applied there where my dad went. I did medicine there. It was a great time. We have a nice campus here, like here in UCLA. It's not at the same level, of course, but the student life it was really unique. So I studied medicine there, and after finishing med school, I moved to Buenos Aires for the ophthalmology residency. And Buenos Aires has better programs, so I applied there.
And how long was your residency program?
At that time was 3 years. Nowadays, 4 years, like here in the States.
And how long was your fellowship, and where did you do your fellowship?
Well, most of the American country, we have really a very informal fellowship. So at the end of of the residency, I stayed in my home hospital, and I stayed for 2 years doing retina cataract surgery. But we lack of teachers. The problem is that it's a public hospital, and public medicine sometimes is going through many troubles. So most of the attending have to leave early to move to their private practice. If not, because there is most of them go ad honorem to do medicine in the public hospital. They go just for free. So we don't have teachers, and we have to teach to learn by our own. And after these 2 years, I went to Boston for a observership in corneal diseases. I spent time with Roberto Pineda, and when I was doing cornea, I have a really tough time in Boston because of the weather. It was terrible, but I learned a lot. And when I was there, I realized that I like retina. I went in between surgeries with Dr. Pineda. I jumped to the retina ward, so I shared time with Demetrios Babas and Dean Elliott, and I realized that what I really want was retina. I got bored doing the LASIK procedures. So during the winter time there in Boston, I took 1 week off, and I came to LA because one of my colleagues from Argentina suggested me that if what I really love was retina, I should visit Jules Stein. And it turned out to be that at the same time of the year, Boston weather was terrible. Here in LA, it was sunny and people was nicer. Maybe the weather has some impact in the humors. So I fell in love with the retina, with the Stein Eye Retina division. I went back to Argentina. I worked for another year, and I applied for the international fellowship here at Stein, and I got accepted. So I arrived at Stein in 2017, and it turned out to be that I didn't have idea about retina. I mean, I thought I understood something about retina before, but being with the colleagues from the US and names like Krieger, Strasma, I realized that I have to study more, and there are many things that I completely did not understand at that time. So the first time JP saw me doing Jean-Pierre Hatchman, that was always also my one of my mentors. After he let me finish one of the cases, he told me, "So, but you don't know how to do surgery. When you apply, you says you knew it, but there are many things you lack." The same thing happened with you, Steve, when we were reading an FA, and you told me, you asked me to describe findings on the FA, and I completely wipe out. I mean, so
This is
there
not my recollection. I remember you knowing everything.
no, I mean, you have to dig deeper than that. I'm sure you
Well,
remember
and so
things.
after your fellowship, thank you for those kind words. After your fellowship, you returned to Argentina, to Buenos Aires, and tell us about the setup that you're in now, the clinic and the environment that you're in now.
So the fellowship was a life-changing thing. It really changed my mind and changed the way I think about the eye and the retina. It helps me develop the criteria about the eye. So with those tools, I was able to join one of the biggest practice in Argentina, ophthalmology institutes. But the main thing that this institute has is that it has a huge retina division. So, and also we have of course a medical retina area, a surgical retina, and also we have a research unit. So from being I was like a traveler surgeon before the fellowship. I went from one place to other, do some surgeries, taking care of some patient in one place to the other. And when I went back to Argentina, I just set myself in one practice. I joined this big practice, the Charles Ophthalmology Center. this helped me to grow a lot. I mean, I remember advices from the Stein colleague telling me that you need to fly to behind or below somewhere else wing for many years, because you are I went back to Argentina with 35 years, and you lack of experience. Everyone suggests me you lack of experience. You need to build your own reputation. You need to learn more. You need to polish your techniques more. So I find a perfect practice where the main partner is 10 years older than me, and there is another partner that is in his late 70s. So we are different generation in the same practice, sharing the knowledge. So it's a very enriching environment.
Yeah, that's very nice. And are you associated with the training program as well?
Correct. So at the very beginning, we only have 6 residents in our practice. Now the residency grows a lot. We now are 17 residents, and we open it a Retina fellowship program. So this helps me a lot to share what I know, and also it's a 24/7 feedback where the fellows and the resident push me to, because they challenge me all the time with new information. So I find that very, very amusing.
Yeah, the fellow mentor relationship is a very special one. And now that you've seen it from both sides, you realize that the fellows continuously sharpen their faculty and make you better. And it's a really great privilege to have fellows around. Um,
Yeah, and sorry, Steve, but the other thing that made me realize that um now I value even more what I have learned from you and the mentor from my fellow, because from my fellowship, because when someone is teaching a fellow, is sharing their knowledge and the time that took them to learn what they have learned. And our most precious thing is our time. So when we are sharing our time with someone else, that is a unique relationship. And also, mentoring is also goes beyond medicine, because it's a way to teach a way of living. This goes just to a more philosophical plane, but I mean, this is something else really important.
yeah, absolutely. And actually, the more you do it, the more you realize that the greatest gift you can get is to give, and it lends your satisfaction. It makes you a better surgeon. And that's why one of the reasons why you are such a great mentor to all of the residents from Buenos Aires in your program that I've had the privilege of meeting, uh, the brilliant Francesca and Giulietta and others who are just fantastic. And so let's shift gears now to explain to us what Buenos Aires is like. How many people live there, and how many retina doctors are there?
Okay, Buenos Aires is the capital of Argentina. Buenos Aires itself is like Washington, DF. I mean, is the city where politics, economics, and the minister are set. It's a 3 million inhabitant city, but there is a great Buenos Aires, a ring around Buenos Aires, that it has another 12 million inhabitants. So it's a very crowded place, but very unequal. Or there I mean, the things, there are a huge disparity in Buenos Aires. You have very wealthy areas that share the border with the poorest areas of the country. The Buenos Aires is a very cosmopolitan city. Although it's pretty crowded, we lack medical doctors, and we lack specialists. There are in between 200 to 250 retina specialists around the country. The country is pretty big. I mean, its surface is as big as India, is the eighth country in the world, in the top eight, if we talk about its surface. So there are just a few retina specialists, and we need to have more well-trained eye doctors.
So you would say that no shortage of patients.
Correct.
And what are the most common diseases that you're dealing with from a vitreoretinal perspective?
Well, as the rest of South America, Africa, and Mid East, diabetes is by far the most frequent disease, and is a sight-threatening condition. There are areas that they have no access to health, so diabetes is an epidemic. And as you know, is one of the trickiest uh, disease to be treated. If you arrive late, even though if you are able to do vitrectomy and surgeries, the success rate is not good. So we are working in prevention. We are delivering OCTs and fundus color cameras around the country to go for screening programs to detect diabetes before it melt the eye, right?
Yeah. And you also have almost everybody there is of European descent, whether they're Italian or otherwise Spanish and Argentina. So I'm sure you have a lot of age-related macular disease.
Right. Of course, the huge amount of a big percentage of the population has European heritage from Italy, Spain, Germany, and Poland, Ukraine. We have genetic predisposition for AMD. So AMD is the second most frequent disease we see in our office. And we see both. I mean, we see late stage AMD with neovascular membranes and atrophic disease. By the way, when the company named Apellis started recruiting patients for their trials, they went to South America, and we recruit 21 patients in 2 months. So because there is plenty of patients with AMD, and at that time there were no treatment for geographic atrophy. I mean, but luckily we have the treatment available. Most of the insurance and the government pays for the anti-VEGF, so we have a good coverage for wet AMD.
And how about for dry? Is the government and the payers, are they covering the complement inhibitors?
No, it's not approved, as there is no clinical efficacy. Although it's a statistical difference in between compared to the sham, the clinical benefit is pretty low. So the regulatory agency did not approve the drug, and there is no sponsor that wants to commercialize the drug in South America.
And so are they available off-label? Can you get them for your patients or not at all?
Not at all. No, the only patients that are receiving the drug are the post-trial patients that there is a compassionate use program, but just for the few who were part of the trials.
And it's interesting, you've developed a reputation as a fantastic recruiting site, both for the diabetic trials and for the AMD trials. Tell us a little bit about your research infrastructure. There's a lot that goes into quality recruiting like you're doing, good patients in, good retention, good data collection, and high recruiting numbers. And that's a big effort, particularly in an overburdened setting like the one you're teaching and working in. So how do you do it in Buenos Aires?
Well, at the very beginning, when I right after the fellowship in 2019, we start doing research, sharing the research patient with the regular patient, and this was a mess. I mean, the technicians doing the OCT to patients from insurance, they could not understand why we were taking so long acquiring images from the fundus FAs. So a regular visit from a research patient, it took sometimes in between 2 to 4 hours, whereas for an injury it might be 15 or 20 minutes. So the first setup was we share in the clinic both practices, the research one and the regular one. After a couple of months, we realized we would not manage the research patient as well as we would like. So we decided to open a separate facility on the same block, but completely different unit with our own machines. So we took care of the research patients like a kind of VIP patients. We have to avoid commuting, because as every other big city, commuting in Buenos Aires is a huge problem. So we offer free transportation to all of the patients that are enrolled in the trials. And also sometimes for the screening, even if the patient is not enrolled, we offer free transportation to them. So they always say yes to the screening. If not, they will not come. They need to come with someone else, with the family member, a friend, or wherever. They don't like to come alone. And it's also something very important, because we go through during the screening interview, we go through too many, we give to the patient too many information. So it's always good to if the patient is with someone else. So we have a nice transportation system. We coordinate it's like an army of cab drivers that goes around Buenos Aires, and they bring the patients to our clinic.
So these
This
are
is
people that you employ by the clinic, or it's a service that you're just paying for?
No, the service belongs to the clinic.
So you own your own fleet of drivers.
Correct. Correct. The other thing is that referring doctors, the referring doctor from our clinic has a limit. It has a ceiling. So what we decided to do is like install facilities or give support to another colleagues around Buenos Aires. There are many practices that, economical reasons, they lack OCT or fundus cameras, so we support them. We have installed OCTs in those practices, so they do the OCT, they show us the OCT, they can use the OCT by their own practice, but if they detect or they find patient that might be candidate for trials, they refer those cases to us. So that's help us increase the volume. The other thing is that we are moving to a paperless research unit. We have hired software with this runs by artificial intelligence. It's very intuitive. That's make us save a lot of room and space in our clinic, in our research department, and it has a speedy all the flow of the patients in the research unit once the patients arrives. So those are the main clues to have a nice research unit. And of course, the working environment is really nice. I mean, you think about something else. You set your focus outside surgery and regular visits, and it helps you to think ahead and to think in new drugs and trial designs. It set your mind in a different way.
Yeah, one of the things that I know about you is that you're extremely creative, and it's always hard when you're creative to limit your research to protocols that are written by others or written for specific aims that may or may not
Yeah.
align with your own. So have you begun to design your own trials?
We have, but those are about images. I mean, we acquire new OCTs, new stuff, and we do those things more for fun and because we like to understand diseases better than we are understand them now. So we have our own trials. Most of them are based on medical and surgical retina. We are not capable of having our own assets to design our trials to test drug, but we have designed trials to to test some devices, surgical devices or devices for AMD. We have done, for example, a small pivot trial for dry AMD, where we test doing an angioplasty of the ophthalmic artery to see if there were some benefit of increase the blood flow through the choroid. We have done some trials on PVR. We have done some trial on ultra wide field OCT, but those are pretty small.
So I remember when you were a fellow, you really loved the imaging trials. Can you describe some of your favorite projects that you've published before we come to your surgical innovations, which are many, and I have lots to ask you about? You're attending this weekend here in Los Angeles the Pacific Retina Club and the INTEREST, the International Imaging Symposium, hosted by David Saraf and Voss Sada and Bailey Freund and others. And it's one of my favorite meetings. And I'm share with our listeners what this meeting is like, the Pacific Retina case studies, and then the interests, and then tell us about some of your favorite presentations from this week. Not your own. We'll come to that in a moment.
Sure. Well, this is there are two meetings going together. It's a joining meeting in between, as you said, Pacific Retina and the International Retinal Imaging Society. It started this last Thursday, and it's a 3 days meeting. At the beginning of the meeting, colleagues from all around the world, and literally people that come from Australia, China, Japan, South America, and Europe, and of course the States, has presented in challenging cases. So sitting in the auditorium were the masterminds of the retina, surgical and medical retina. So those is very I really enjoy listen to the discussion after every case. So it's a very enriching environment. And after the case discussion, there is an update about the cutting edge technology and treatments. And what impressed me the most is the project to transplant the whole eye. Los Angeles University of Los Angeles is involved in that project, and they have settled the criteria to transplant the whole eye, the whole human eye. It's very ambitious, it's very challenging, but now there is a group that brings this to reality. Let's see if it works. It has many technical steps that have to be resolved, and there is nothing conclusive yet, but it's another way to help people sites.
Yeah, that's an exciting project, and it's spearheaded by Jeff Goldberg at Stanford and Jose Sahel in Pittsburgh. But you're correct, Aya Barzilay at UCLA is leading the robotic portions based on a lot of the technology that you participated in when you were a fellow. So it's probably very exciting to you to see the technology grow up and be used in other ways. And then for the case presentations, what are you presenting at this meeting?
Well, we present an a case of absent foveal vascular zone in a patient that was diagnosed with essential ataxia many years ago. And the patient now complains about blurred vision and metamorphopsia. And a colleague from Argentina sent him to the psychologist. And when the OCTA, we realized there were still superficial and deep capillary plexus over the fovea, and there was leakage all around the foveola. So the patient was injected with anti-VEGF, and it turned out to be that the leakage was almost gone, and all the symptoms that the patient was suffering were completely gone also. We send the patient for a genetic test, and it turned out to be that it has a gene, it's a syndromic disease that combine absence of foveal vascular zone plus spasticity. It was misdiagnosed as a essential ataxia. This is a very interesting case. And the other thing is that since last year, we've been working with an OCT, an ultra wide field OCT. It's an OCT that runs a source of 400 kilohertz. It's a swept source OCT. Normally, we have in our clinic the spectral domain OCT that has like a speed of 85, in between 85 to 100 kilohertz. So this is 4 times more powerful. We tested and we tried in a couple of patients, run to getting OCTs in the gas field, in the eye completely filled with gas. In cases, for example, where we have done macular hole surgery, and before this OCT was very difficult, very tricky to get nice images of the retina when the eye is completely full of gas. But with this machine, we are able to see the retina as if the eye will be full of BSS or vitreous. We have the same quality of the images. So with this OCT, we can see the early stage of the macular holes. When the eye is full of gas, we barely see the ILM flap. And for example, if you decide to do a PPV with ILM flap, but now we are able to see the flap itself and how the hole heals during the early stage. It's a very interesting, we will be able to get very interesting images.
And do you think that will, what you learned from watching the flap during the early postoperative period will, or has it already changed your technique for macular hole?
A couple of things. Yeah. First of all, we saw, or we have detected hyperreflective biomarker. There is a hyperreflective line in the middle of the hole. This might be linked to healing, the healing process, and this hyperreflectivity might be the Mueller cells contacting each other. And in all the cases we have seen that hyperreflectivity, all the holes closes. And whereas there were a couple of cases that we were not able to see that hyperreflectivity line, that the holes remain open. There was one cases, we only just have analyzed 32 cases. There's a very, very few. It's not is anything conclusive, but the case that we are not able to see the hyperreflective line and they remain open. The holes that remain open, we were able to see the flap covering the hole, and this case was open after the gas gone away. But with the flap covering the opened hole, we decided not to do surgery, and we put the patient on drops. We use anhydrase carbon inhibitor plus non-steroidal anti-inflammatory plus steroidal inflammatories, and after 4 weeks, the hole completely closed and the ELM completely regenerates. So might be some cases that there is a delay healing, whereas there was one hole that did not close at the end of the follow-up, that we never detect the ILM flap. We couldn't see the ILM flap sign. And also we didn't see the hyperreflectivity in the middle line, and this hole remained open. I might require a new vitrectomy to close it. So maybe we can tell which holes might take longer to heal. This is one thing. And the other, there is no real need to position the patient's face down. It will be enough with the gas for most of the cases.
And what's the brand of the OCT that you're talking about? What's the company?
So the company is named Tower P Company. It's a Chinese OCT.
Say it again.
And the name Tower P, Tower Pi. So, and they have
So this is an ultra wide field OCT with spectacular OCTA images as well, if I recall.
Correct.
And does it take one image or does it sew them together?
You can do a line. If you decide to do a line, you can do a raster if you want to do a raster, or you can do a ultra wide field OCTA 24 by 20 millimeters. So you have the whole retina, and it's able to get the entire retina under gas. Yeah, you cannot tell the difference if the patient is under gas or under BSS or has the vitreous.
And what is it about the optics of this machine that you think facilitates the gas-filled eye being imaged so readily?
The acquisition speed, because you are able to take the whole eye in 10 seconds. This prevents you to getting artifacts. And also, they have been very smart and they develop 3 tracking levels. There's no tracking at all, full tracking, and mid or a light tracking mode. So in order to have the same reference OCT, the same scan, instead of doing the full track that it will take longer, you can select a mid or low tracking mode that they only just pick a couple of references in the fondos, and this allows you to run the scan pretty fast and is not affected by eye movements or movements from the patient chest. Or so this is something really fun to have.
And do you find that this OCT is clinically useful in your clinic, or are you using it only in the research unit?
No, for clinic is super useful. For example, in cases that you are not able to see the retina with a regular OCT because it has media opacity, for example, the cornea is cloudy, it has a corneal decompensation or has a advanced cataract. When we don't have a clear view of the retina with our regular spectral domain OCT, you run this OCT and you have a completely clear view of the retina. It's amazing. You have a colleague from anterior segment referring you a patient that says that he doesn't know if they have a healthy retina because they want to do a corneal transplant or a phaco, or whichever. You can see precisely the retina. This is one thing. The other one is most of the trials we talked about trials before include neovascular membranes that are up to 10 millimeters square, right? I mean, they don't include huge membranes. But then when we are in our clinic, we see a bunch of patients, and there are some patients that are non-responder or bad responder to our anti-VEGF drugs. And with this OCT, we have seen that we have in between 10 to 15% of our patients that we are treating for wet AMD, that they are low non-responder at all. They still have fluid despite frequent injection, despite being injecting them every 4 up to 6 weeks, and they still have subretinal fluid. We also have injected them with twice the regular dose of aflibercept before having the aflibercept 8 milligram or before having faricimab. And when we got images of the retina from those patients with the ultra wide field, with this ultra wide field OCT, we were able to see that the membrane goes beyond the posterior pole. Some membranes goes up to the vascular artery, or they have satellite lesions. So, of course, this patient will not go well with the regular treatment because the disease is more severe. So this changed our approach for the non-responder. And the other important thing is that it allows you to do line scans in the periphery. So I always remember Dr. Alan Krieger's work of peripheral lesions, which he have shown us many histological images of the periphery, and he taught us during the grand rounds about how to deal with RDs, that when the RDs has some lattice present. Now with this OCT, we got the same images as Dr. Krieger used to show us. We have histological images of lattice lesion, the tuft lesions, so you can evaluate the periphery precisely. I have zero commercial interest or relationship with this brand, but this just, I'm telling you what we are able to get. We have nice cases where, for example, there was a young lady, 25 years old, that was referred to us from a colleague that wants to implant a phakic IOL. That there are many cases that when some colleague implant these phakic IOLs in myopic, most of them, of course, are myopic patients, and years after they develop RDs and retinal detachment, and those cases are a nightmare to repair. You have to remove the anterior chambiol, take the lens, the cataract or the crystalline lens out, doing an encircle band plus the vitrectomy, a nightmare. So we have some cases where we see those cystoid degeneration that we always see where we are indenting or doing the exam of the periphery, and we have seen patients with cystoid degeneration that already they have a shallow RD that is not possible to see in the regular office with our fundoscopy exam. The vitreous is attached in the periphery. There is no, maybe those are low risk progressions RDs, but anyways, we are getting images of the disease that we haven't seen before.
Well, that reminds me of the paper you did with us looking at retinoschisis detachments versus retinoschisis.
Right.
And that was also with the Optos ultra wide field. And are you using the Optos imaging as well?
I'm using the Optos all the time. We have several Daytonas in our facility, so all the patient, they as soon as they enter in our clinic, we got an Optos images of both sides for sure. And also we have the Silverstone from Nikon Optos with the peripheral OCT. And we have the California. So we are doing our FAs and the FAF with the Optos, the California, and the Silverstone. Yeah, I mean I cannot imagine running the practice without the ultra wide field Optos imaging.
And
Not
tell our listeners about the paper that you wrote to distinguish the peripheral RDs versus the schisis detachments.
right. During my fellowship, we were analyzing ultra wide field images, and we realized that RDs and schisis RD and schisis without RD, they looks different when we run on them ultra wide field fundus autofluorescence. So what we have seen is that the patient that has schisis, peripheral retinoschisis, without RD, in the FAF fundus image, there is no hyperfluorescence. The schisis lesions looks alike the rest of the retina or hypofluorescence. Whereas when the schisis, the retinoschisis, is linked to an RD, what is named retinoschisis retinal detachment disease, the border of the schisis looks hypoautofluorescence, and if there is fluid, it looks hyperautofluorescence. So when you have an schisis, you run a fundus autofluorescent image, and you see at the border of the schisis hyperautofluorescence. That might mean that there is subretinal fluid, and the schisis might be associated with a retinal detachment. To corroborate what I'm saying, we have run peripheral OCT in those cases because OCT is the gold standard to define if there is a schisis or RD, and we have corroborate that the patient who have schisis and in the autofluorescence, they have hyperautofluorescence at the border of the schisis, they have an RD's association.
Yeah, it's a spectacular paper because those patients are so hard to sort out. We've all spent lots of time deciding whether a patient has retinoschisis or a schisis-associated detachment or a straight detachment.
Correct.
And we've all seen catastrophes where patients are operated either with a wry operation or when they don't need an operation. It's also a wonderful way to determine whether or not a ski assist attachment that doesn't have any brakes, that's just tractional, is progressive or stable.
Correct.
So it's a wonderful observation that you made, and congratulations on that innovation. Going back to the ultra wide field OCT, one of the sets of images that I am completely blown away from that machine or that family of machines are the choroidal vascular images.
Correct.
The OCTAs of the choroid are
Mhm.
stunning, and I'm wondering if you can share. I'm sure you're managing retinal neovascularization and retinal ischemia in your host of diabetic patients. But if you had the opportunity to think about or study choroidal hypo or hyperperfusion in some of these eyes, given the ultra wide field perspective that you can now get with that OCTA?
Well, it's amazing. First of all, we lack ICG in Argentina, and we also lack PDT. So no one is commercializing both drugs. So we could not assess the choroid properly. Now with this OCT, we can get an incredible image of the choroid. Of course, we cannot see leakage because it's an static image, but we can see if the choroidal vessels are dilated, they respect the RAFI or they go beyond the RAFI. If they have a choroidal flow overload, we can see and we can distinguish the choroid in central serous chorioretinopathy or dome-shaped maculopathy. So this gives you a completely different understanding of the choroid. So for one of the main advantages of this machine is that you are able to scan to have nice images of the choroid, and you can do a post-acquisition Photoshop on the images, so you have more precise um, I mean, you have more precise quality of from the choroid. Of course, we lack of treatment for those diseases, but at least we have a whole completely different understand, and also the patient that most of the time is very anxious and they do not understand why they have suffering from both diseases. We can show them what is different from a normal patient.
Yeah, that's great. I'm looking forward to you and others learning and sharing with us your insights. You're fortunate enough to have those machines. They have not received clearance for commercial distribution in the United States, but they are available here under research guidelines, and a few of them are around. But I'm really happy to hear that it's in your hands. One of the other pieces of research that I love that comes from you that I'd like you to share with your our listeners here on Retina Rounds is some of the surgical tricks that you've published, the maneuvers. One of my favorites is with a ring, creating a controlled retinotomy. But why don't you talk to us a little bit, Anibal, about some of your surgical tricks and tips. And for example, for our audience, this is one of the best surgeons in the world. This Anibal Francone has fantastic hands and super creativity, and he couples that with a uh, deep sense of responsibility and privilege for his patients. So it's not a Argentinian cowboy we're talking to here. We're talking to the real deal. And so when we talk to us about some of these tips that you have, first about the problem you encountered and then what your solution was.
Well, first of all, I want to thank you for your words, and fortunately, I was gifted by the position at UCLA to learn how to buckle. I think there is still a role in buckling surgery for RD cases. So, although we are a young generation of ophthalmologists, we have to learn how to put a buckling in our patients that are suffering for retinal detachment. Even
And
though
if I can just interrupt you, that's one of the reasons to watch Retina Rounds because Dr. Prasad is in the process of a series of how-to scleral buckle videos, and they're both from the absolute simplest steps to the most complex subtleties. And so you can look for more and more surgeries, both on historical buckling and modern day buckling from Dr. Prasad's Retina Rounds. Sorry to interrupt.
No, it's a pleasure. It's true. That is true. It's very useful. New generation need to learn that. But although we do everything for our patient, there are sometimes that we have the patient or the eye develop peripheral vitreoretinopathy (PVR). That is the main cause of redetachments. So one trick is just to have good OCT machines to assess the retina properly when there is a redetachment, because we can see the epiretinal membranes, subretinal membranes, so we have a plan when we go to the surgery. This is very important. Most of the cases recur because we don't have a nice or we don't understand what's going on, and we just go into the eye, we take the oil out and take the oil in, and there is many more things to do for the eye. For example, doing an extensive peeling of those epiretinal membranes that prevent the retina to reattach. We publish a series of cases where we combine the removal of those epiretinal membranes with the removal of the internal limiting membranes. It's a very time-consuming procedure, but our series is pretty small. It's just only 14 cases. But we found that in those areas that were removed the ELM, there is no regrowth of epiretinal membrane. However, I think that with the new drugs like methotrexate being approved for intraocular use, might not be a real need to do an extensive ILM peel. So we are injecting or prescribing methotrexate for those difficult cases. There are some, I mean, there is no clear protocol for injecting them, but I think it's a very useful treatment that we have to have as a tool when we are doing retinal surgery.
Absolutely. What about the stabilizing the retina with a loop when you are removing subretinal membranes? Can you describe that for our listeners? And where can
Correct.
you find it?
Yeah, there is a tool for surgery that is a loop made with nitinol. That is a flexible but a very stable material that it was designed to peel the ILM or ERM at the posterior pole. But we found some other uses for it. For example, when you have a retinal detachment and you have subretinal bands, there is difficult to get rid of those bands. You have to make a hole in the retina, take the bands and pull the bands out. And sometimes while you are pulling the bands out of the retina, you can damage the border of your retinectomy and it can bleed. You have a subretinal bleeding, and also it might obscure your view during the surgery because it bleeds inside the eye. So the idea was to do the retinotomy as we are used to do it, close to the band. There are some surgeons that prefer to do it over the band, or others do it just juxta the band. But the thing is, doing the retinectomy and place this loop over the whole of the retinotomy, and through the loop and through the whole of the retinotomy goes with your regular forces, with serrated forces, grab the membrane and pull it, and the loop acts as a counter pressure, so it reduces the retinal mobility, and it reduces the risk for retinal damage. It's a simple maneuver, but it's very useful for those tricky cases.
And where did you publish that?
We didn't publish.
Where did I see it?
No, I presented in a couple of meetings, Retina Society, some meetings and other meetings here in the US, but we didn't have time to sit and publish it.
You
Sorry.
should.
Yeah.
We're gonna ask you to share that video with Retina Rounds because that's
Sure.
a really important use for the lens for the ILM loop or whatever that instrument is called. What is it called?
Finesse loop.
Yeah. And it does it. It's beautiful because it restricts the expansion of the band as it's coming out of the retinotomy, and therefore it reduces or eliminates, in my hands anyway, expansion of the access retinotomy to those bands, which is a really nice thing because occasionally they will tear and bleed, as you mentioned, and it's it's particularly nice for people who aren't used to taking out bands. What it does is it will make more surgeons comfortable addressing these bands. And as you know, not all subretinal bands need to come out. Oftentimes in young people, while we're just buckling a detachment, there will be subretinal bands that can do fine. But if they're transecting the macula or they're tenting the retina, or you go to flatten the retina and the band is holding it up, it can be a very good idea.
Yeah.
Or if they're recently occurring bands following a retinal detachment repair that was successful and now it's becoming unsuccessful. So there are lots of indications for addressing subretinal PVR in a band form. And I really like that technique. In fact, we refer to it as the Anibal loop. So I know that's not what it's called, but that's what we're used to. That's what we are used to asking for. And Anibal, the name of your clinic in Argentina, one more time?
It's Charles Ophthalmology Center.
Charles Ophthalmologico.
It's in the heart of Buenos Aires.
And I hope you don't mind, but I'm about to invite the world to visit you in Buenos Aires. So Dr. Francone is one of the most gracious hosts you'll ever find, and he would love to hear from you when you visit Buenos Aires.
Yeah, more of
But beware because he might put you to work. And I want to thank you for spending time with our listeners today, Anibal, and congratulate you on your career trajectory, your fellowship program, your residency program, and thank you on behalf of all of the patients in the greater Buenos Aires area. And I'm certain that everyone in Argentina is extremely proud of you. I guess there's one last question for you, which is, do they play football in Argentina?
soccer. Yeah,
Are they doing okay now or
we are doing okay. Yeah, we are the champion of the world.
okay? I just wanted to make sure. Okay, Campeón del Mundo, Anibal Francone, thank you very much for joining us on Retina Rounds today.
Thank you for your words. You have helped me a lot during my entire career. Thanks.
If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.